basic type of suicide prevention program. It's generally offered for communities so that people within a community can rally together and look out for one another. So it's a very basic principle. It's sort of that same idea that if you see something, say something, of course, so that when you either have a coworker or a patient or a neighbor or a friend, if someone looks like they're really struggling, teaching people that it's okay to
we're
ask.
obviously doing that right now.
Yeah.
Teaching people that it's okay to ask if the person's thinking about suicide or feeling suicidal. And what we're going to do today is an example of that. So healthcare systems have had to adapt in the post-COVID-19 world. We've got work-life imbalance, many people either working from home, some people losing their jobs or being laid off or furloughed. We have telehealth, which is kind of an interesting quote. I don't know if you all have heard people use that. Certainly stresses associated with needing PPE, some people experiencing shortages of PPE, some folks experiencing a lack of clear protocols and how their roles have changed in a post-COVID-19 world. And then of course there are things like compassion fatigue, which are comprised by burnout and vicarious traumatic stress, which I believe you've had a recent webinar about, so I'm not going to go into that in depth. But at the end of the day, there's a new paradigm upon us, at least until we have a vaccine or a treatment. And so our worlds as healthcare providers have been turned a bit sideways or upside down, and certainly our patients' worlds have been turned upside down. How is COVID affecting us? Well, let's take a look at the age-adjusted hospitalization rates associated with COVID-19 by race and ethnicity from March through June. What you'll notice, let's start on the right there, the non-Hispanic white rate is about 40. Now, again, these are per 100,000 of the population. Non-Hispanic Asian Pacific Islander, about 48. And then Hispanic Latino is about 4 times that, same as non-Hispanic Black. And then non-Hispanic American Indian or Alaskan Native are over 5 times that rate. So what we're seeing is people of color being disproportionately affected by this. The contemporary thinking is that that is partially due to the social determinants of health, but it also may be due to some biologic factors. There is some recent research looking at blood type as a specific vulnerability to COVID, with blood type O folks being quite a bit more resistant. So this is important because it obviously is a snapshot of what our patients may experience, but it also, we may experience this. We know that we do not have herd immunization yet, which means that although we have flattened the curve, which accomplishes the goal of making sure we have enough medical resources for the potential demand of patients in need, while we have flattened the curve, what we do know is that many more Americans need to get this before there is herd immunity. And so we should expect continued COVID positive tests in the next few months. The good news is that we are seeing the death rate actually decline. That's likely, and many of you already know this, that's likely because those who are most vulnerable to it, some have already gotten it. The newest trends in spikes of who is getting COVID are the 20 to 30-year-old population, and they, of course, have a better prognosis, assuming they don't have any complicated medical conditions or autoimmune diseases. So let's talk a little more specifically about suicides during COVID-19. Since COVID-19 pandemic began in the US, the rates of these risk factors for suicide have increased. We are seeing increased rates of anxiety, depression, increased domestic violence. We've seen an increase in relapsing from alcohol or substance abuse disorders. And we've also seen a rise in other indicators of risk, like phone calls to the national helpline, and that's for emotional distress. However, suicide rates have not been higher since January 2020 as a result of COVID-19. So I think that many people expect that it will peak or will spike a bit because of this. We won't be able to tell that for probably a year or two Typically, the CDC aggregates its data in 3-year increments in order to make sure they have enough statistical power to properly assess suicide rates. Now, having said that, we don't even have short-term indicators that it's spiked. But what we do have is increases in risk factors for suicide. So what are the implications of this? It means that we need to have some self-awareness about what we're experiencing and how this is affecting us. If you are experiencing a work-life imbalance, if you are experiencing job instability, if you are experiencing stress associated with maybe a loved one having COVID or being scared of COVID, and maybe I know many people who have elderly parents and they're doing all their grocery shopping for them, things like that. Be aware of what you're experiencing and most importantly, make time for self-care. Then, of course, as good gatekeepers, we have to be paying attention to what our patients are experiencing. So if you are doing any kinds of screeners routinely, pay close attention to those. I would discourage you from doing them in a perfunctory sort of box checking manner, but rather to stick to the scripts and stick to the ways that they are supposed to be administered in the most evidence-based way, so that you do give your patients the opportunity to disclose maybe some personal or sensitive information that has arisen since COVID. And finally, we've got to have awareness of what our team members are experiencing or may be experiencing. This just helps us, again, be better gatekeepers. If we're taking care of ourselves and we're taking care of the people to our right and our left, we are much more equipped to take care of our patients. So with regard to taking care of team members, we don't have to know everybody in depth or very personally. We just have to be able to look for changes in their baseline behavior, changes in how they communicate, changes in their tolerance to stress or adversity or frustration, and just know that when those things pop up, that they're okay and that we shouldn't be afraid to address them. And we'll talk in the next 45 minutes here about how we might address those things. Before we can be good gatekeepers, we have to grapple with a few important questions. Now, these are rhetorical questions, so I'm not going to ask for responses. What I will do, though, is give a quick poll at first to get us started. I'm going to ask the same question 3 different ways. I'm going to ask, before you vote, in a moment, Ann will put up a poll. It'll be a yes/no poll. And what we'll ask is, are you very comfortable treating suicidal patients or dealing with suicide risk? And the next question is, so you would answer yes, I am very comfortable. Then we're going to have sort of moderately comfortable and sort of not so comfortable. So we'll have 3 different questions. You should only vote for 1 question. So why don't we go ahead and launch a poll? And the question is, I guess the statement is, you're saying, yes, I agree, or no, I don't. I am very comfortable managing patients with suicidal risk. Now, these, if you notice, these are 6-question polls. That's a glitch on our end. So just answer the same thing for every question. So in order to complete it, you'll have to click, let's say you want to click yes, you'd have to click yes for all of them. And so we should expect some percentages here. Let me be clear, though, for us to understand this. Everybody, actually, I made a mistake for everyone has to vote for every question in order for this to work. Sorry about that. So, question 1 is, are you very comfortable managing suicidal patients? Those who feel yes, answer yes. Those who are probably going to answer moderate or low comfort, answer no. And we'll give about a minute for the results to tabulate, and then we'll share them quickly. So you should see a poll pop up on your screen, a prompt to fill out yes or no for that. And again, the question is, are you very comfortable managing suicide risk? And once we have about 75% voting in, if we can go ahead and end the poll and show the results to be cautious of our time here. Okay, so about 64% of you are, so 2/3 of you are very comfortable. So now the next question is going to be, actually, we only need to ask one more. The next question will be, are you moderately comfortable? So those who before said they were very comfortable, you want to answer no. And of course, those who are not so comfortable, you want to answer no. So go ahead and we'll reiterate the poll one more time. Actually, you know what? Let's not do it, Ann. Let's cancel it. To know that 2/3 are very comfortable, that tells us that the other third is somewhere below that. So that's fine, just for the sake of time. So 2/3 of you are comfortable. That's great news. One of the most important goals when doing a training like Prosper is to make sure that people have high comfort in managing suicide risk. Then the second issue is, are they comfortable because they're doing the right things, right? So we can be comfortable, but not realize that we may not be following the most recent evidence-based literature. And so we want to sort of make sure both of those are verified. Are you comfortable, and are you doing, using the best tools possible, putting the best foot forward? Before we can do anything for our patients, for ourselves, for our neighbor, for our coworkers, we need to consider our own biases and beliefs about suicide. These are rhetorical questions. I'm going to go through each one and just reflect on them and think of what you would answer. Why do people kill themselves? What do I believe morally, spiritually, and/or religiously about suicide? What type of person makes a suicide attempt? Can suicide be prevented? Who do I know who has been suicidal, made an attempt, or died by suicide? What do I think about my own personal thoughts of death, dying, or suicide? How have the suicide deaths of my patients influenced my practice habits? And what is my responsibility to my patients as a clinician? So these are important because we all have biases, whether they're gender-based, culture-based, race-based, ethnicity-based. They might be just based on family values or family of origin. And so we have to think about our biases and then figure out, okay, well, in light of those biases, we all come from a different angle, from a different perspective. What can be done about suicide? Well, there's some bad news here and some good news. Let's start with the bad news. The bad news is that at a population level, there is a persistent upward trend. If you look on the left side, the light red line are females, and the darker red line are males, and the black line are the total suicides from 81 to 2016. Those are per year. And on the right side, if you look at this chart, this takes a look from 2006 to 2011 about suicide compared to accidents, all causes of death, diabetes, and heart disease. Now consider that the top 10 causes of death largely involve conditions that have behavior as one of the major components. And so we continue to struggle with things like diabetes and heart disease, and yet when we look longitudinally, those are decreasing compared to suicide. So the bad news here is we haven't yet cracked the nut with regard to suicide. We're not nearly with suicide where we are with things like the flu, for example. So this is the audience participation part. You can use the chat box, or you can unmute your mic briefly, but who dies by suicide and after what kinds of events? What do we know about people who die by suicide? They're likely to be what race, what age, what gender? Give a few facts that you know that are sort of common knowledge about suicides. Go ahead and either pipe up or type it in. And I'm even going to go back to make it a little more tricky. What kinds of events precede suicide attempts? Good. So we're seeing males, we're seeing relationship breakups, financial crises, loss of job, financial problems. Elizabeth Augustine says access to means. That's very, very true. Firearm owners are more likely. Carla says someone who's had suicide in a family. Relationships. Good. So you're all hitting the nail on the head here. These are all the factors we know that routinely precede suicide, and certainly the types of people. So that's good. We know our data. White males age 18 to 35, firearm owners. So here's the question though. Don't females, people of color, and people who are not 18 to 35 kill themselves? Don't people kill themselves in ways that don't involve firearms? At the end of the day, has knowing all of these facts help us prevent suicides over time? This is a really unfortunate, uncomfortable question. The answer is no, it hasn't. Let's go back. This is what the suicide rate looks like. Monica, you're dead on there. Anyone and everyone is susceptible. So knowing these facts has not helped us change the suicide curve. So on this webinar today, we're going to challenge you to think differently. Here's a reason why it hasn't helped. These are the 67 risk factors that are related to suicide. We've known the profile for the suicide person for over 50 years. We've known these facts for over 20 years, and yet we still are not able to bend the suicide curve at the population level. The reason why is because these sorts of conclusions come out of a specific type of research called between factors. They look at 1,000 different people who killed themselves and figure out what are the common denominators that occur in a higher likelihood than just chance, just probability. But the problem is then we apply those in what's called a within subjects manner, meaning I am a provider and I see the same person over and over. That's not an appropriate way to use those statistics. And the evidence that it's not appropriate is the fact that our suicide rates continue to climb. We even have a meta-analysis and another study that came out last year showing that considering the last 50 years of suicide research, our ability to predict future suicides and suicidal behaviors at the population level is generally poor. So I'm not saying forget everything you know or think you know about suicide. What I am saying is we have to do something different. Otherwise, we should expect the same outcome, which is continued suicides. So for example, our typical risk assessment looks at risk factors like those 67 on that slide. It looks at protective factors and then thoughts, plans, and intent. Let's start with the top. When someone comes in and complains of depression, do we do a risk assessment for whether or not they're likely to have depression? Or do we treat the symptoms in front of us? When a patient comes in and it looks like they've had a biopsy, let's say a melanoma, some sort of skin cancer, do we do a risk assessment calculation for their likelihood of skin cancer? Or do we treat the cancer that's in front of us? I hope you see what I'm getting at. The fact of the matter is when a patient comes in and says, I'm thinking of killing myself, it makes no sense to go back and do some retrospective risk assessment with a bunch of check boxes to figure out what categories they fit in. If the person is telling us that she is suicidal, we should attend to the specific symptoms she's experiencing. And that's what we're going to talk about today. As for this part over here, where we just focus on thoughts, plan, and intent, that is insufficient and it's antiquated. That is not an effective way to assess suicide risk. Here's a problematic cycle that we see in our community. This is present in mental health providers, PCPs, ER providers. We have a better safe than sorry approach, a cavalier approach, and then something in between, which is what we're aiming for today with this training. Those who take a better safe than sorry approach will hospitalize more prematurely. They'll use a crisis response plan in a rather routine or perfunctory way. At the end of the day, patients have negative experience. Type in the chat box if you've had patients before who have been hospitalized and had a negative experience. In fact, as I train thousands of people in this, I seldom have people say that patients have a positive experience. Well, part of the reason why is because we haven't done as well as we can in assessing it and collaborating with them. And when we take a better safe than sorry approach, it sometimes creates this us and them, or you feel like a game of cat and mouse. If we are putting our best foot forward in doing this risk assessment in the most effective evidence-based way, there is no cat and mouse dynamic. It is highly collaborative, and you are empowering the patient to make the healthiest decision for himself or herself. The cavalier approach is when people don't ask because they either don't know what to do or don't think they have resources in their community to help manage it. That's potentially violating ethics, and certainly it increases risk and liability. In those cases, just like the better safe than sorry approach, the standard of care isn't met. And so just like up here, the client isn't safe, right? So risk is not mitigated. We want to go for an accurate approach here, and that's what we're going to continue talking about. There's also a miscalculation that many systems make, which is that we just need more beds. If there's a shortage of mental health providers and there are a plethora of suicidal patients, we just need more beds to help these patients. There's a problem with that mentality as well, folks. The problem is that there's never been a robust set of studies or even one RCT showing that psychiatric hospitalization decreases suicidal symptoms. What psych hospitalization does is decreases the opportunity to attempt suicide. That is to say, it functions to make the patient safe, not to treat the patient's symptoms. And so that's why the post-discharge rate is about 100 times the global rate during the first 3 months after discharge. It's also why patients admitted with suicidal thoughts or behaviors have about 200 times the global rate when they're immediately upon discharge. It's also why we see 1 in 4 patients attempt suicide within the first 7 days of discharge. Now, it's not only that there's not specific suicide symptom-based treatment going on in these hospitals, it's also because of the step down from a highly supportive or intensive level of care and treatment to a less intensive one. And of course, when they do step down and get discharged to outpatients, oftentimes they're being put back in the same circumstances that precipitated their suicidal thoughts. So we don't have a choice here. We're going to have to take this bull by the horns. It's the outpatient medical community that has to solve this problem. It is well within our role. But there's another problem hampering us here, and that's that studies have shown that less than half behavioral health professionals get formal training in suicide risk management in graduate school. Less than half. And the average duration of that training is less than 2 hours. Could you imagine if cardiologists were only less than half of them were trained in managing an MI and a heart attack, and that training was 2 hours long? There's no way in heck that would fly. But for some reason in our field, this has happened among mental health professionals. To make matters worse, when we survey mental health professionals and say, hey, are you comfortable doing suicide risk assessments? Do you routinely ask about it? What we find is that one recent study of psychologists found that they are reluctant to provide services to patients who have elevated risk. And when we say, why are you reluctant to provide this care? They say, well, I don't think I have adequate training and I don't have enough resources in the community. Another recent study of all different types of therapists, so this is social work, psychology, this includes licensed professional counselors or mental health counselors, about 1/3 were not asking every patient about current or previous suicide risk factors. And they found out that it was the more comfortable they were, the more likely they were to use evidence-based strategies. So that should bring us full circle as to why one of the underlying goals of today is to get you to be more comfortable asking, because then you're more likely to use the evidence-based tools. When we're not comfortable asking or we're not fluent in a certain skill set, we get rusty. When we get rusty, we either get hesitant and avoidant, or we fall back on old knowledge. With regard to what that knowledge is, it's likely to be old, right? It's likely to be outdated research about how to assess suicide. Remember that on average, it takes 17 years for research to hit the field. So when we develop a particular intervention, let's say EMDR, when that's developed in a research lab for PTSD, it takes on average 17 years for that to truly enter the community mental health environment. So again, even more reason for today's training to try to accelerate that curve. Much of the research we're going over is a decade and a half old. Some of it is very new, but we have known how to do this for a few years now. Just some stats for you. The prevalence rate for suicidal ideation and behaviors in general medical settings is generally 2 to 5%. Suicide remains one of the top 10 causes of death in America among adults, and among children and adolescents ages 10 to 18, it remains the #2 cause. If you are an integrated behavioral health provider working within primary care, you can expect the prevalence to be about 12%. We know that anywhere between 1 and 10% of primary care patients experience suicide at any given time, suicidal symptoms, excuse me. And of those who die by suicide, 45% saw their PCP within 1 month. 20% saw their PCP within 24 hours. And among the elderly, 73% of those who die by suicide saw their PCP within a month. So the take-home message here is that the primary care domain is the best window of opportunity to detect these folks, to catch these folks, and to help them. Now, some people would prefer a better safe than sorry approach. They'd prefer a as indicated approach. So if someone says I have chronic pain, if someone says I have depression, then maybe we'll screen for suicide. But there is a reticence to do routine screening. The problem with that approach is that when you look at the people who die by suicide within the 45% who died by suicide within 1 month of seeing their PCP, here are the top 5 chief complaints in those appointments preceding their suicide. If you notice, 40% are things that we would do an as indicated screening, that is anxiety and depression, but the other 60% are not. So that's unspecified GI symptoms and unexplained cardiac symptoms and hypertension. So if we only use an as indicated approach, we're going to likely miss 60% of those people who are going to leave this appointment and die by suicide and attempt suicide. So one last point about this, I've worked with many internists and family docs and hospital administrators who say, look, in the primary care domain, we are responsible for so many conditions. We can't just pile on other conditions like suicide. I just don't have the time, is sort of the message we often hear. Well, I can appreciate that. That's partly why we have the patient-centered medical home model, so that we have a team to assist with these types of screenings and follow-up questions. The second point is that, can you name another fatal condition that you can mitigate as quickly and inexpensively as asking a question? Are you thinking of killing yourself or ending your life? That is a question that takes under 10 seconds to ask, and it is not an expensive test, by contrast with some types of labs or other radiology or other, radiology or other types of imaging that we might do, biopsy, et cetera, some sort of test. So the juice is worth the squeeze, as they say. So let me hit pause there and see if there are any questions or comments.
If you please use the chat box to communicate your questions or comments.
I think, Dr. Corso, one of the comments someone wrote in the chat box that statistics were shocking.
Yes, the idea that 45% of people die by suicide within a month of seeing their PCP and 72% within a month among the elderly, they are shocking statistics. But when you look at the trends, which just continue to ascend at a 30 to 45 degree angle, it's not that shocking. It's because we are missing the opportunities to help these patients. And we have to think of suicide like any other condition. And so this is called the fluid vulnerability theory. It's that suicide risk is comprised of baseline risk, which are your predispositions and static risk factors. So, genetics, biology, race, gender, things like that. And then acute risk factors, which are short-term risk factors based on any current events going on in the person's life. This is no different than depression, anxiety, ADHD, cancer. We all have baseline risks for all sorts of conditions, and how we live our lives and what happens to us in our lives can determine whether or not the symptoms precipitate or not. Quick question in the chat box: how accurately do clients tell the truth? I actually don't have studies on that I can talk about. I can't quote you one, but what I can say is the majority of patients tell the truth. It's only when there is the presence of personality disorders, when there is something to be gained by feigning these sorts of things, malingering, those sorts of things, like potentially within forensic settings or prison settings. Another comment by Sherry Woods: I looked at depression more than anxiety for suicide. So just to comment here, suicide is a distinct constellation of symptoms. It is not just a part of depression. It is not just part of the borderline personality. It is a distinct condition that we need to address outside of depression. Remember that in this list of people who died by suicide, we have people with GI symptoms, cardiac symptoms, and hypertension. The bottom line is when people are sick and suicidal, they still go to the doctor, right? And we'll talk about why that is, how they can be thinking of ending their lives, but then still taking care of themselves by going to get some GI symptoms taken care of. We'll talk about that in a moment. But we know that if suicide risk is not addressed, then it tends to be progressive over time. And so we all play a different role here. This is from an article we published in 2014, looking at how to work within the patient-centered medical home. What role does each person play? I'm not going to go through this at length. You'll see some similar roles because we should all be functioning as gatekeepers to identify and refer. But then there are some other specific roles based on what your role is within the PCMH. Travis says that certainly takes future orientation out of the mix. Could you expand on that while I go to the next slide? I'd love to see what you're getting at there, Travis. Very, very thought-provoking comment. So these are our roles within the clinic, but here's what our role is not. We cannot be a friend. That means we also cannot be rent-a-friend, which is a sort of someone who's just passively listening to the patient, nodding, trying to support, but not teaching them new skills. We can't be a guardian, a savior, or a protector. These are not appropriate roles. There are many within the mental health field, behavioral health field, who transcend professional boundaries with suicidal patients. They use their relationship to keep the patient alive, and there are problems with that. That's sort of a whole other ethics discussion, but there are problems with using the relationship as the vehicle to keeping the patient alive. Our job is to follow the standard of care. Of course, we intend for no patient to die. Just as a surgeon goes into the OR and does a surgery, she doesn't necessarily do everything she can to keep the patient alive. She follows the standard of care. Now, she may have to use clinical judgment here and there, and that's totally appropriate. But if we really think our job is to keep patients alive, then we should be taking them home, putting them on 24/7 watch, feeding them until they're not suicidal anymore. I'm sure you'd all agree that transcends boundaries in a very obvious and not acceptable way. Getting back to the chat box, thanks Travis for elaborating. What you mentioned is if you're senior PCP, that might reflect having some future orientation, which would be a good sign. You're absolutely right. It is a good sign, and it may even be a protective factor. But the problem is protective factors do not reduce suicide risk. There's a misunderstanding in the field that if someone has several protective factors, they are at lower risk, and the data do not show that. What protective factors might do is buffer against risk, but not reduce it. So protective factors are actually de-emphasized in evidence-based risk assessment because they're not good predictors of what will come. Thank you for that comment, Travis. Very helpful. So our role is not to keep them alive. Our role is to follow the standard of care. Enter yes in the chat box if you've ever found yourself working with a suicidal patient and found yourself sort of doing a little CYA in your documentation or a little CYA in talking about the case with someone. Answer yes or no in the chat box if you've ever found yourself doing a little bit of CYA with suicidal patients. There's no shame here. It's actually a very common experience. I'm seeing yes, 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 yes. I was seeing someone say, I was trained to do it that way. Absolutely. And these are bad habits. Let's just fess up. These are bad habits of ours. If we are following the standard of care, there's no reason to do CYA. The reason why we do CYA is because we either not sure of what the standard of care is, or we mistakenly believe that our role is to keep them alive. That is not our role. Some patients will die. Of course we don't want them to die. Of course we don't want them to kill themselves. But our most safe way to proceed is to follow the standard of care, because that also gives the patient the best chances of survival, because the standard of care is based on what the research has said works. And it's actually, let me back up. It's really based on what court cases say is negligent clinical behavior. What we're talking about today is the evidence-based research that can help you meet the standard of care so that you are not found negligent or found guilty of malpractice. Above all things, do not try to talk the person out of killing himself. This is another bad habit that many of us do. Would you even know what that sounds like? It usually sounds like, well, don't you think if you just ... or, well, what would your family say if blah, 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 or, well, maybe if we just did this, blah, blah, blah. That's sort of talking them out of it. It also means don't talk them off the ledge, okay, which is a nuance of this. If someone's feeling powerless and hopeless, to talk them out of something takes away more power. And if it does work for today, it's not giving them anything to learn from. So we want to teach people to fish. We don't just want to hand them a fish for today. So instead, we want to help them learn to cope. We know that when they have a stronger sense of meaning in life and purpose, there is lower emotional distress, the SI is less severe, and they have better functioning. We know that if we do an effective crisis response plan, now effective is in quotes because there are many studies around crisis response planning. The latest and greatest says that if we talk about reasons for living with the patient in a very meaningful way during a crisis response planning, and then it's integrated into their crisis response plan, that we reduce suicide attempts up to 76%. Guys, we don't even have data this good for depression. Our depression treatments aren't necessarily this good. And then there's a very brief CBT manualized treatment that reduces suicidal behavior by 60% compared to treatment as usual. So we want to help patients cope, and that involves empowering them, not moralizing them, respecting that they can deceive you at any time and kill themselves, respecting that even if they don't deceive you, they might be honest with you, but they can still go home and kill themselves. So we want to avoid power struggles because that creates the cat and mouse, which undermines their autonomy. It makes it us and them instead of creating a collaborative alliance where we can help them make the healthiest decisions. Suicide is a state of hopelessness, burdensomeness, powerlessness, thwarted belongingness, and above all of these, it's a state of ambivalence. This is why people come into the doctor when they're sick and suicidal. Most people who are suicidal have reasons for living and reasons for dying. And when we talk to them, very few of them want to just die. The people who want to just die are already dead. They are not going to come in for help. And if they do come in for help, what they will tell you is, I know I'm going to kill myself. The time just isn't right. And that's not them being squirrely. That's not them being deceitful. If you've finally decided to kill yourself, just like people finally decide to buy a house, finally decide to retire, sort of some permanent decisions, you want to do it right. You want to do it in a way that suits your values and your priorities. And so for some people, they'll say, yeah, I'm going to do it, but I don't know when. So they're determined to die. So they'll either tell you or they'll deny any suicidal symptoms. These are the cases. And again, this is a very small minority of the cases we see where people say there was no sign. We had no idea that he always seemed like such a happy guy, or whatever, the sort of sentiment is. And so the people who come in to see you, by the mere fact that they're coming in and talking to you, is proof of their ambivalence. And that is the best way to open the dialogue with them as you're getting to things like intent. We'll talk about that in a moment. Suicide is a way to escape our suffering. It's an escape-oriented behavior, and it's just one solution in the patient's problem-solving repertoire, which is why if you have a family member who's killed themselves, you are of slightly higher risk because it occurs to you as one potential solution for a problem you might come in contact with later in life. Another very important concept for you as we fly around, and we got about 15 minutes left to sort of fly around these slides. There's something called the suicidal node. You need to be able to recognize this in the moment when it's happening in your clinic, whether it's among a coworker or whether it's a patient. Again, we all have predispositions, and then there's a trigger. It's not going to help us looking at these and trying to use these as to pick out who's going to kill themselves, because plenty of people have dispositions and triggers and don't kill themselves. What we have to do is look at some other very important factors, like, for example, the suicidal mode. If the patient's suicidal mode is on and they're in clinic, it's going to sound like this, they're going to feel like this. Their physiology, there are all sorts of physiological changes, including psychomotor agitation, there are racing thoughts, there's sleep disturbances often, concentration problems or distractibility, and then there are behaviors that coincide. Our job when someone comes into the clinic is to turn this mode off. Please hear this clearly. Turning the mode off does not mean talking them out of killing themselves. Turning the suicidal mode off does not mean talking them off the ledge. What it means is helping them choose life, helping them struggle through their ambivalence and making a decision to engage in treatment and use a crisis response plan. That is the evidence-based way to help patients. And here is your process. Here is your step-by-step. There are 5 skills. We're going to go through them very quickly. You will get these slides at the end. This is something we published in Professional Psychology Research and Practice in about 2009. If you're familiar with the Columbia instrument for suicide, it's based on the same research. We were creating this while they were creating the Columbia. If there are questions you want to ask about a suicidal patient, but they don't appear on this flowchart, according to the research, you don't need to ask them. You don't need a chart of the 67 risk factors. You don't need to check those boxes. Those aren't going to help you predict who's likely to kill themselves and who's not. But these questions will, which is why they have instruments like the Columbia. Skill 1, differentiate between suicidal ideation and non-suicidal ideation. Non-suicidal ideation is also called morbid ideation or death ideation. This is just thoughts of death or thoughts of dying. Some people use the PHQ-9 as a suicide screener. That is not an accurate way to assess for suicide. If anyone has a PHQ-9 handy, you can reference this. It does not assess for suicidal ideation. It assesses for death ideation and for self-harm behavior, non-lethal self-injury, to be specific. The reason why this is an important distinction, and most mental health providers, most medical providers, most nurses, most ER folks confuse these two. Suicidal ideation reliably results in suicidal behaviors, but death ideation does not. So suicidal ideation is associated with higher levels, higher intensity of emotional distress, higher severity of suicidal thoughts, and associated with intent. But death ideation is not. So the first question out of your mouth should be, are you thinking of killing yourself or ending your life? And if they say, well, I've been thinking a lot about my death, you need to clarify, well, do you see yourself playing a role in your death? Or do you just think a lot about not being here? Because many people think about not being here as a relief to their distress. So that's the first thing that has to be distinguished. If it's just death ideation, you can exhale. They are not at high risk. After each skill, I'm going to share just a list of sample questions. I'm not going to go over them. This is for you to print out later and put right by your computer screen so you have a reminder of how to proceed. Again, I recommend you use this, put this by your computer screen as well, so that you have sort of a cheat sheet. Skill 2, assess for past suicidal behavior and multiple attempts. Over and above other risk factors, past suicide attempts, not past suicidal thoughts, past suicide attempts are the most robust predictor of future behaviors, whether they have other risk factors or not. When we look at the research and classify people into multiple attempt, single attempt, and people who are just thinking about suicide, we see that the multiple attempters' risk starts higher and ends higher. Now, multiple attempt is defined by 2 or more previous attempts. When we look at these data a different way, here is the baseline risk. This dotted line or dashed line is the acute crisis. Your 0 attempters hit the acute crisis, escalate quickly, and resolve. And then time goes on, back to baseline. Your multiple attempters start much higher. They escalate exponentially, and look how long they take to resolve their risk and distress. These are the folks who are not good predictors of what's about to happen. They're not a good reporter of their symptoms. And for that reason, objective indicators are better predictors than subjective indicators. So things like, do you own a firearm, or do you have access to means to kill yourself? Is anyone likely to interrupt you or find you? Are you the type of person who has the courage to do it? And someone's survival reaction, particularly within this category of patient, can be a great indirect indicator of intent. When someone wakes up in the hospital room after a suicide attempt, if their first thought and feeling is, dang it, I can't believe I'm still alive, that's indicative of continued high risk. However, if they wake up and say, oh my gosh, thank goodness I'm alive, that was really stupid, then then there's likely a lower risk. This will probably be the last, one of the last questions I ask. Type in the chat box, true or false, the people who have had more or just one attempt, true or false, people who have had just one attempt, the vast majority of them will attempt again. What do you think? Among people who've had one attempt, the vast majority will attempt again. Looks like we have 2 trues and a handful of falses and no's so far. Keep voting. A few more trues. So the answer is false, okay? The vast majority of people who have one attempt do not reattempt. And this is good news because again, we want to discriminate who is at this chronic moderate risk, which are your people who have 2 or more attempts, versus people who are not at this chronic moderate risk. Here are the sample questions for that one. Finally, we're going to assess the current suicide episode. Please note that if the patient says, no, I only have death ideation, and no, I've never had a prior suicide attempt, your risk assessment stops. There is nothing more to assess. There is no question about plans because they're not planning to kill themselves. They're not even thinking of killing themselves. You don't talk about intent because that's irrelevant. And you certainly don't do a safety plan or crisis response plan because that's irrelevant. People in the mental health profession alienate patients all the time, taking an overly cautious approach, asking about plans, intent, and doing a safety plan when the person's not even thinking of killing himself, which just makes the patient feel as if, wow, this person really doesn't understand what I'm experiencing. I don't think I'm going to talk about that again in the future. So remember, there is one more question you want to ask, and that's access to means. But if the person has death ideation and no prior attempts, the only other question you ask is, do you have access to firearms or any other lethal means at home? And consider doing something about that. So we're going to proceed with skill 3, assuming the person has either multiple attempts or said, yep, I am having some SI. It's not just death ideation. I am thinking of killing myself. So we look at thoughts and desires, plans, preparation, rehearsal, intent, and access. When we look at people's plans and when we look at suicidal thoughts, they break down into 2 categories: desire and ideation, resolve, plans, and preparation. These factors on the left are much better predictors. They're much more heavily weighted than the factors on the right side. That is why if there are 2 or more factors from the right, we consider it mild risk. And if there's 1 or more from the left, it's considered moderate risk. Remember that if anything above these is severe or extreme. But remember, if someone has 2 or more suicide attempts in the past, even if they were 20 years ago, they're automatically at a moderate risk before we even start assessing the current suicidal episode. One caveat to this, the research does not have an algorithm or decision tree yet. We do not have a reliable chart that says if this happens, it equals this risk and do that. So this is a guideline based on about 20 years of research and best practice. But just to be clear, we do not have a reliable, rock solid predictive rubric that says this equals mild risk, this equals moderate risk. So that's how we're assessing sort of plan and desire. Again, if someone thinks about suicide 20 times a day, that's concerning. If they think about it, duration for 4 hours a day, that's really concerning, right? But then we have to get into intent, and it's a very hard thing to assess. Do you intend to kill yourself? That's not a fair question. In fact, most patients think, okay, I'm suicidal. That means I either have to choose to live or I have to choose to die. And it's a false dichotomy. The reality is most people, when they think about killing themselves, they're ambivalent. They feel both ways. They want to live, but they don't want to live this way. So it makes them want to die. And if you ask them, do you just want to die or do you just not want to live this way? They'll say, well, if I didn't have all this crud I'm dealing with, of course I would want to live. And that's the key to assessing intent, is asking them about intent in the context of ambivalence. Helping them, and here are 2 or 3 different ways to ask these questions, but we've got to really narrow the scope down and make it super simple, high structure. Are you feeling ambivalent? Is it that you only want to die or that you just don't want to live with all the pain and suffering you have? Sometimes we know that patients cannot spontaneously voice reasons for living or positive factors when the suicidal mode is turned on. So they may have trouble acknowledging or identifying with the ambivalence. A good thing to say if you get into that circumstance is, well, then why are you here today? What brought you into clinic? That's evidence that you're ambivalent because it's an effort to help yourself. So don't collude with them that they only want to die. If they did, they wouldn't be alive still, or they would tell you it directly. Few points about access. The bottom line is that whatever you have is the item you're most likely to use. It's plain and simple. So if someone really, really intends to die, that doesn't mean they'll use a firearm versus someone who kind of wants to die is going to take 5 Tylenol. Intent does not correlate with lethality. Access correlates with lethality. And in fact, when we talk to people who have attempted suicide by firearm and survived, we say, how much time elapsed between you thinking of killing yourself and actually picking up the gun? 24% made the decision to act within 5 minutes. 70% made the decision to act within 1 hour. That means 94% of the people who have survived gunshot suicide attempts made the decision to act within 1 hour. That is why means restriction, particularly for firearms, can be so effective. We've seen in some data, it decreases suicide rates up to 50%. Think about that chart where the suicide rates are just climbing, climbing, climbing over the last 50 years. If we just reduce access, we can decrease that by 50%. And that doesn't mean taking away people's Second Amendment right. What it means is when we use the research shows, and these data are in press right now being published, they're not published yet. When we use motivational interviewing and help people understand that merely by having access to their firearm, they are at higher risk, they make a healthy decision. When we teach them that if they just delay access or find a way to make that access harder, they end up keeping themselves safer, they make a healthy decision. Skill 4 is to discuss reasons for living. Now remember, you've already talked about ambivalence with the patient. So you've primed the pump a little bit. And so before we discussed how you have ambivalence about reasons for living and dying, you don't really want to die, but you can't stand living this way. So what would you be enjoying in life if this stuff wasn't on your plate or if you weren't experiencing this? And you want to start to get them talking about reasons for living. The ambivalence and reasons for living is what turns off the suicidal mode. So here are 5 different ways to talk about that. And lastly, the skill 5 is a crisis response plan. Very critical. There are 5 sections, warning signs. And so these are not just risk factors like I own a firearm. It's the exact behaviors, the exact feelings, and the exact thoughts this patient experiences in that little suicidal mode diagram. Because these are the flags the patient needs to use to say, oh, I need to take out that CRP because I'm experiencing that now. So CRP is not an administrative item, it is an intervention. The first starts with what signs they're having so that they can recognize it. The second are self-management skills. Oftentimes, patients may not have healthy self-management skills, but you'll want to, for those people, do the sort of crux of DBT, which is emotional regulation skills and distress tolerance skills. And then you want them to write down reasons for living. And so that when they are reading their CRP in the moment, they remind themselves of their reasons for living. Then we have social support, people to reach out to, and crisis and professional services. The key here is that this should be this should be tailored to each individual patient. And you shouldn't put anything down here that the patient's not really going to do. It has to be realistic. Put the pen and paper in the patient's hand and teach them how to fill it out. Do not write it for them. There is no need to have them sign it. It is not a legal document. There is no need for you to keep a copy in the medical record. It could help, but there's no requirement that they must sign it or that you have to keep a copy in the medical record. Remember, you are empowering them to write a short list of solutions for when they're experiencing these thoughts and feelings. Here are some resources for you. We've got probably a minute or 2 left, so I'm going to wrap up. Here's some resources for you. Here are 2 books that are excellent. The one on the left is specifically for primary care. I get no kickbacks or any royalties for pushing these instruments. Here's my email address. If you have further questions or comments or I can ever help, I am happy to chat with you. Don't hesitate to reach out. And I thank you for your engagement and your time. I will turn it back over to Anne. I am happy to take some questions too if we run a few minutes over.
Yes, if anyone does have any questions for Dr. Corso before leaving, please put them in the chat box. For those of you who want continuing education credit for this webinar, you do have to complete the NASW approved evaluation form, and we would very much appreciate for the post-survey question as well. So thank you very much. And if anyone has questions for Dr. Corso, please put them in the chat box.